Today, we're diving into a major new study comparing two common medications for chronic pain, Pregabalin and Gabapentin. Both drugs are widely used, especially among older adults, as alternatives to opioids. But recent research has raised important questions about their safety, particularly regarding heart failure risk. In this video, we'll break down the findings from a large-scale investigation published in JAMA Network Open, focusing on Medicare beneficiaries aged 65 to 89. Let's explore why this study matters for patients, families, and clinicians alike. Chronic pain affects nearly 1 in 3 older adults, making effective and safe treatment options essential. Pregabalin and gabapentin, known as gabapentinoids, are often prescribed instead of opioids due to the latter's risks of addiction and overdose. Over the past 2 decades, the use of these medications has steadily increased in the United States, especially among seniors. But as their popularity grows, so does the need to understand their long-term safety profiles, particularly in vulnerable populations. Both pregabalin and gabapentin work by binding to specific subunits of voltage-gated calcium channels in nerve cells. This action reduces the release of neurotransmitters and helps control pain. However, these drugs can also affect calcium channels in the heart and blood vessels, which may lead to cardiovascular side effects. Notably, pregabalin has a higher potency and stronger binding affinity than gabapentin, raising concerns about its potential to increase heart failure risk. Despite their similarities, clinical reports and regulatory agencies have flagged pregabalin as potentially riskier for heart failure than gabapentin. The American Heart Association and European Medicines Agency both recommend caution when prescribing pregabalin to older adults with cardiovascular issues. Yet until now, few studies have directly compared the heart failure risk between these two drugs in a large high-risk population. This study aimed to fill that gap. Researchers used a method called target trial emulation, which mimics the structure of a randomized clinical trial using real-world data. They analyzed Medicare claims from 2015 to 2018, focusing on patients aged 65 to 89 who started either pregabalin or gabapentin for chronic non-cancer pain. Importantly, anyone with a history of heart failure or terminal illness was excluded, ensuring the study focused on new cases of heart failure. Final study cohort included over 246,000 Medicare beneficiaries. About 18,600 started pregabalin, while more than 227,000 started gabapentin. The group was mostly female, with a median age of 73. Researchers carefully balanced the two groups for over 200 health and demographic factors, ensuring a fair comparison. This large sample size and careful matching make the findings especially robust. Main outcome measured was the first hospital admission or emergency department visit for heart failure. Researchers also tracked outpatient heart failure diagnoses and all-cause mortality. By focusing on new heart failure events, the study aimed to reveal whether starting pregabalin or gabapentin made a difference in real-world risk for older adults. During over 114,000 person-years of follow-up, 1,470 patients developed new heart failure. The rate was 18.2 per 1,000 person-years for pregabalin users, compared to 12.5 for gabapentin users. After adjusting for all relevant factors, pregabalin was associated with a 48% higher risk of heart failure events. This difference was even greater among patients with a history of cardiovascular disease. Beyond hospitalizations, pregabalin users also had a higher rate of outpatient heart failure diagnosis compared to gabapentin users. However, there was no significant difference in all-cause mortality between the two groups. This suggests that while pregabalin increases the risk of developing heart failure, it may not necessarily lead to higher overall death rates in the short term. Study also looked at subgroups based on cardiovascular history, race, and sex. Pregabalin's risk was especially pronounced in those with prior cardiovascular disease, white patients, and women. For example, among patients with cardiovascular disease, the risk of heart failure was nearly doubled with pregabalin compared to gabapentin. These findings highlight the importance of individualized risk assessment. The study stands out for its size and methodological rigor. By including over 246,000 patients and adjusting for more than 200 variables, the researchers minimized bias and ensured a fair comparison. The use of real-world Medicare data means the results are highly relevant to everyday clinical practice, especially for older adults managing chronic pain. Despite its strengths, the study has some limitations. Most participants were female and white, which may limit generalizability to other groups. The analysis was restricted to those aged 65 and older, so the findings may not apply to younger patients. Additionally, some factors like lifestyle or socioeconomic status weren't captured in the Medicare data. Still, the researchers used advanced methods to check for hidden biases and found their results to be robust. For clinicians, these findings underscore the need for caution when prescribing pregabalin to older adults, especially those with existing cardiovascular risk factors. While both pregabalin and gabapentin can be effective for chronic pain, the increased risk of heart failure with pregabalin should prompt careful risk-benefit discussions and close monitoring. Personalized medicine is key. Study authors call for further research to confirm these findings in more diverse populations, including younger patients and racial or ethnic minorities. They also suggest exploring the mechanisms behind pregabalin's higher heart failure risk. As the use of gabapentinoids continues to rise, ongoing surveillance and research will be crucial to ensure patient safety. Summary: this large study found that starting pregabalin for chronic pain in older adults is linked to a higher risk of developing heart failure compared to gabapentin. The risk is especially high for those with existing heart disease. Clinicians should weigh these risks carefully and discuss them with patients. As always, the goal is to manage pain effectively while minimizing harm, especially in our most vulnerable population.